Hey, Dr. C here with you. Let's talk about hair loss and how it relates to thyroid disease and what you can do to help it get better. This is a super important thing, and I think I think there's a sense of guilt that people have about just how emotionally powerful it is. Well, it is. Take it at face value and don't judge yourself. It's a big deal. It affects so much of how we see ourselves, how we feel that others see us, our thoughts about our own health and vitality and attractiveness, and it cuts deep. It's a really big thing. And not only that, it's really important to realize that hair loss is a symptom. It's not a diagnosis. And it's a symptom that's occurring because your body is not repairing something correctly. And that's important all for what it is just at face value, but it's also important because of what it implies. If things aren't being repaired well in part of your system, that's going on elsewhere too. And there's some underlying problems that are affecting you in other ways. So it's critical for its own concern, but also for your overall health, to really understand this and make sense of this. In many cases, this can be one of the first signs of another disease process to show up. A big orienting concept too is to realize that it's a slow indicator, both when it comes and also when it goes away. So when your body shifts in some way that causes it to start, that usually happened in the prior 3 to 12 months. And on the other side, when you identify what that problem was, you get better. It's often about 1 to 3 months to see hair loss start to stop or slow down. And it's often about 12 to 18 months to see hair really come back in again. So I want to start off with a few things that are just not intuitive, just to throw those out in our opening discussion. A big one is how this overlaps with thyroid disease. Now, many people with thyroid disease have hair loss, and many people have hair loss because of thyroid disease. There's a difference. there's an important difference. So hair loss, let's think about first the demographic. So if we're talking about women, 30s, 40s, 50s, 60s, there's a large number in that population that has hair loss. And there's a large number in that population that has thyroid disease. So those things can overlap. However, it's possible to be a woman with thyroid disease and hair loss and have the hair loss not come from the thyroid disease. It's also possible to be a woman, to have hair loss, to have thyroid disease and anemia, and have the hair loss not from either of those. So in some cases, we predict that based upon what pattern the hair loss is, when it showed up, what the levels are like. But in some cases, we only know that for sure after the fact. Once you fix whatever cause there is and it gets better, we can say that was the real culprit. Another thing not intuitive is how degrees of thyroid disease can relate to hair loss. As a generalization, definitely too much or too little thyroid hormone can cause hair loss. However, it's not typical that small differences have big effects in this case with this symptom. We think about symptoms like fatigue or brain fog and metabolism, and there's really good data in which changes that are well within what's considered normal, like subtle differences in thyroid levels in and outside optimal, can completely make or break those symptoms. But that's not as common for hair loss. It's more typical that we're talking about more extreme thyroid abnormalities that contribute, like the really big highs, the really low lows. And we'll talk too about thyroid autoimmunity. We've got how much hormone your body has, and then whether or not your body is attacking your thyroid. They're different things, and they relate to hair loss in different ways. So also for laying some foundational stuff, I want to talk about some terms. So one I'll use is effluvium, and that's just excessive daily hair loss, too much loss going out. Alopecia means just visible hairlessness. There's just some areas you can see that should have hair, but do not. So anagen, this is the growth phase of the hair follicles, and this is typically about 2 to 6 years. So any given follicle will be in that anagen phase for a couple of years, then it does not. Then it goes into the next stage, which we call telogen. So telogen is the rest phase of the hair follicle. And during that phase, the hair falls out. And that'll last about 2 to 4 months. So healthy follicles, they come and go. They turn on and off. And they're generally on longer than they're off, but they're not on forever. So that's why some hair loss is perfectly normal. And that's also why it takes time. So let's say that there's some chemical reason by which you had many follicles go into telogen, go into a rest phase. Well, that phase will last for months. So it might take 4 months, even if you switch the cause, for that hair follicle to move out of telogen. And then it'll take however long before the visible hair comes back again. A few more basic ideas. So adult men and women, we both have about 80 to 120,000 hairs at any given point in time. Oftentimes women have thicker hair, more keratin, so fuller head of hair than we have as men. But yeah, around 100,000. Any given day, a healthy person can have 100 hairs that are lost. A lot of variation with that. It could be 40, it could be a few hundred. My beautiful wife, we just cleaned the cars this last weekend, and there's a lot of long red hair in the car. It's all over the place. And she's not shedding or anything, but it's just normal. It's just normal that it sheds, so that some is lost. And when hair is longer, it's more visible when it's out, when it's falling too. You can just see it more commonly. So some triggers for normal hair loss. One can be oral contraceptives, and that can be either starting or stopping them. Then we have a thing called postpartum effluvium, which is just hair loss after pregnancy. And what happens is that the stress, the hormonal changes, some mixture of that causes many follicles to go into their dormant stage. And that's about 2 to 4 months post-delivery. So it's really normal to have a lot of hair shedding, a lot of hair loss, just from the hormonal shift that goes on. Perfectly normal. Many women will see that a couple months post-delivery, and that's a pretty tough time already. You got a new baby, and maybe it's the first one, and your body's going through a ton of changes. So yeah, and at the same time, there can also be thyroid disease, anemias, abnormal cortisol. A lot of other factors can be present too, but sometimes that can happen just as the normal course of affairs. And then we think about chemotherapy. Those that need chemo for cancer treatment, there can be direct damage to the follicles. So not even just triggering telogen, but actual damage. And that can come on about 1 to 3 weeks after. Now, an odd irony about that one is that once those follicles become active again, their growth phases are synchronized. So typically hair comes back thicker than it was before. All right, so here's an important distinction. First thing you got to know with any medical condition is, what are you really talking about? Because remember, hair loss is not a diagnosis, it's a symptom. So we want to be more granular and talk about the types of hair loss and how they're relevant. So the 3 main ones I want to talk about are going to be androgenetic alopecia, alopecia areata, and telogen effluvium, also called non-specific hair loss. Okay, so there's actually a few more details with that too. But these are things that can all be more common in those with thyroid dysfunction, especially diffuse alopecia, the more non-specific versions. Of all of them, alopecia areata is the least relevant to thyroid function. That's bald circles, that's little patches that have complete hair loss. And I want to distinguish too that we've got the abnormalities of the thyroid levels and then the autoimmune disease. So they're different things. So we'll talk mostly about the dysfunction, but I will talk about how the disease affects hair loss too. So for starters, you want to know how to tell which type of alopecia that you've got. And sometimes you can see by the patterns of hair loss or the nature of that. There is a tool called trichoscopy, and that's quite simply not a microscope, but more than a magnifying glass and a device to visualize the hair closely. And you can see that on the scalp. You can also take some hairs out and look at them under the trichoscope and evaluate the health of the follicles and their integrity. But that's the main way that can be well differentiated. That's done by dermatologists. Dr. Linda Kashaba in Integrative Health is also a trichoscopist. She does do trichoscopy. Fun word to say. But yeah, she can also do thorough diagnosis for evaluating causes of hair loss. And even those who are remote, this is a cool thing, but she can instruct you on how to extract a sample, drop it in the mail. And, not a chemical hair analysis, but a visual hair analysis to make sense out of hair loss if you're remote. So the most common version is androgenetic alopecia. And this is a situation in which androgenic hormones, the male-like hormones, are related to hair loss. And this affects both genders. Now, in women, this shows up by really clear hair loss along the midline of the part. That's where it starts and becomes the most dramatic from the midline. It's not as diffuse all over the head, it's more so there. And adult women, 40% of them can have some level of androgenetic alopecia. This can relate to hormone levels when cycles are irregular. And that can be cortisol elevation is one thing. HRT, so women who are given DHEA or testosterone, this can be a culprit for that. And something that's not intuitive, but it's not even how much you're given. Now, if anyone gets a high enough dose, if any woman were given a high enough dose of those hormones, it's almost inevitable they would eventually get hair loss. Most women can have reasonable doses and have no hair loss. But there are many women to where it doesn't matter the dose, they can get hair loss as a side effect. That is possible. So it's not always a matter of, oh, am I losing hair because of my hormones? I should check my blood, see if they're too high. Not always the case. It can just be from ingesting them, regardless of how much that there is. We also think about PCOS, polycystic ovarian syndrome. This is a situation in which the women are generating too much androgenic hormone, especially testosterone, sometimes cortisol as well. But in these cases, we can see a crazy combination of hair thinning, that androgenetic pattern, but also facial hair growth or hair growth elsewhere that wouldn't be expected. Acne can show up with that too, but those things tend to cluster with PCOS. So for men, about 70% of us will get some level of androgenetic alopecia. And in our case, it's more so, it's going to be along the temporal lines and the occipital whorl, the little bald spot that forms in the back. I still feel some hair there, but probably not as much as there was a decade ago. So yeah, those are the main centers they start from, and then of course they can spread from there. Now, like women, we can have that aggravated by hormone replacement therapy. It can be triggered by that. It is a function of our hormones and specifically how we make testosterone into DHT, dihydrotestosterone. But then it comes down to how the immune cells around the hair follicles respond to DHT. So it's not that we've got too much hormone. So yes, you can give someone a lot of hormone and make them lose their hair, but on the other hand, those who are not taking hormone, their hair loss is not proportionate to their own body's hormone output. So a man couldn't say, oh, my hair is thinning, I should check my levels, see if my testosterone or DHT are too high. Those are not predictors of it. It's what goes on in the cells, not how much is throughout the whole body. And that's kind of the conundrum of that too. It's not a sign of being unhealthy or being hormonally imbalanced. A lot of it is just what happens locally in ways that are genetically driven. And these traits are X-linked. So for women, you wouldn't really know which familial side it came from because you get X chromosomes from each parent. For men, we get one X chromosome from our mom, right? So it's from the mother's side that those things are passed down. So with chronic telogen effluvium, this chronic excessive thinning, we want to see if there are any causative factors. And I'll talk more about some things that can be causative factors for all of these conditions, but the first step is to see if any contributors are present. But then the treatment is also considered if there are ways to address it. And the treatment, even if there's not yet a clear cause, or if that's not been sorted out, it can still be a consideration to do things that may be helpful treatments, just because it's such a slow process. I mentioned how it might be 12, 18 months before it comes back again. Well, if it takes you 3 to 6 months to really identify and resolve an underlying cause, that's that much longer before your hair comes back. So it's not irrational to say, let's identify the cause and let's do some non-specific treatment. That's quite reasonable to do both. In terms of conventional treatments now for androgenetic alopecia, these mostly relate to changing the local chemistry and how the body responds to the hormones. So the mainstay for women is minoxidil. And this is a compound that really blocks the activity of dihydrotestosterone on the cell receptors. Once or twice a day, it's applied topically, different concentrations. It doesn't have whole body effects. It doesn't so much come into your bloodstream across your scalp and change your circulating levels of hormones. So not a concern that way. The effects of many treatments are subtle and are delayed. Minoxidil can even cause more follicles to go into the telogen phase. So it's quite common to see that in the first several weeks, there's more hair thinning. That can happen. That can actually be a sign of it being useful. With men, as far as conventional treatments, minoxidil is also an option, as is finasteride, which is an oral compound. And the finasteride, it's a smaller amount taken once daily by mouth. Generally, it's more effective than topical minoxidil. Now, I have mixed feelings about it because there are some strong concerns about men having lasting side effects. And I've seen conflicting data on that. Some data argues that there's no real mechanism by which they could have side effects after the pills have been cleared and left the body. And there's also some arguments saying that many men seem to. Maybe the side effects are real, maybe they're not, but I think there are legitimate concerns. And it's something to where whole body systemically, I wouldn't go into too lightly. I don't encourage that. It's nothing I really did prescribe or recommend for men when I was practicing. So both genders, other things that are well documented, low-level laser therapy. And there's a spectrum. There are medical devices that you do in a clinic. There are caps that you wear. I've seen some good data that some of the devices can have some measurable effects. There's a variety of how many units they put out, so there is that, and some require more usage time than others, but there can be measurable benefits, and there's no big drawback to those. We think too about hair transplant surgery. So a general thing there is that a strap of skin is taken usually from the back of the head where the follicles have a longer lifespan, and that skin is then brought together and closed up, and those follicles are just put where they're needed. So it's a procedure. It can be sore for some time afterward. It can be a 5, 10, 15,000. There's some expense, and the hairs can be a little bit different. The hairs we have on the front are generally softer and more malleable than those in the back. So there can be a change in texture, but under good hands, it can work. The earlier versions of this were not as good. They were large numbers of follicles in chunks, and it came out like a chia pet or something. But the newer versions, they can do single follicle relocations. But it's a viable option. Then we think too about PRP. So this is platelet-rich plasma. And the idea with this is you draw blood, you extract the platelets, and you concentrate the platelets from your blood. And these platelets have undifferentiated cells. They've got a lot of useful chemicals that may help a beneficial immune response, and you put them somewhere you want things to heal. So in this case, they're put in the scalp in areas of hair thinning. So the jury's not out. It looks promising and pretty harmless. No big drawbacks to that, apart from the procedure, getting shots and all that. But yeah, no systemic risks. There's no foreign chemicals involved, so worth considering. Other things that are talked about conventionally are camouflaging. And this is really using things like keratin fibers. There's little flakes that one would choose that fit your hair color, and they attach to the hair, and they just create more of an illusion of hair being thicker than it is, and you don't see the thin areas as much. Rather harmless, rather inexpensive. They can show up on lighter colored fabrics, especially with darker hair colors, but that's a consideration. Then also there are extensions, wigs, partials. So that's the main thing and the main conventional treatments for androgenetic alopecia. Now I want to talk briefly about alopecia areata. This is the third most common. I'll spend the bulk of the time on the chronic telogen effluvium, which is the most typical thing we'll be dealing with. So alopecia areata, the name itself basically means baldness in a circle. And that's really what it is. Not always a perfect circle, but a chunk. There's like one chunk of the scalp that's pretty much completely lost its hair. This usually comes on rather quickly. It's a big spectrum. It can be localized, it can be whole body. I have a friend who's a health expert who has alopecia arealis totalis, which means he's lost every hair in his whole body head to toe, like no eyebrows or eyelashes. So that can happen. It's actually over the course of one's life, it's not an uncommon condition. About 1 or 2% of people get it at some point. And the majority of cases, it is localized. In the majority of cases, it does spontaneously go into remission. It does come and go, and no clear reason why. It seems that it is a little more common secondary to the autoimmune process of Hashimoto's and Graves. So it may relate to the autoimmune process, not as much just the levels of thyroid hormones. And again, highly variable. It could be everywhere long term, which is rarest, or it could be a small area very briefly. And alopecia areata, there's not a lot of great treatments unless there's a clear cause that's found. The one thing that can be a clear cause that's treatable is cortisol elevations. And I'll talk more about that one too. So chronically high levels of cortisol, they can cause hair production and the formation of proteoglycans to go down by 40%. And for whatever reason, that can be something that occurs in some areas, but not always diffuse and all over. So a good thing there is to just do a good screen for cortisol metabolism. That's best done by both blood tests and salivary tests. And I've talked a lot about those in other videos, but you want to check in both ways. And if it's off, you can see by both of those tools whether it's more so adrenal stress or adrenal disease. They're both important, they both can affect the symptom, but they're completely different in how they're identified and treated. So yeah, good thing to be aware of. Now, there's some other types of alopecia besides the ones I mentioned so far that are more inflammatory. And these are all more rare. There's a lot of them. I won't go into all of them, but as a generalization, if there is some hair loss and you see that the skin, the scalp is red, it's inflamed, it's bumpy, it's scaly, if there's some scarring that's showing up, this could be one of those inflammatory alopecias. And again, there's a lot of those. So if you're seeing some signs like that with the hair loss, just some signs of abnormal skin, scarring, redness, bumpiness, scaling, do get to a dermatologist, do get a more specific diagnosis. Some of these have really good treatments, but they can be quite specific to the disease process. So yeah, good thing to get sorted out. Okay, so the bulk of our discussion will be on what's the most common condition, but the one that's most relevant to thyroid disease is chronic telogen effluvium. So this is the non-specific hair thinning. Now, how this looks different, remember, so alopecia areata was baldness in a circle. You got a bald circle, so it's not that. And remember that the androgenetic alopecia was more so like midline or temples, more specific to where it started. So this is also not like that. So this one, the chronic telogen effluvium, is much more diffuse and much more even. So it's going on just really all over the head pretty evenly. The group that gets this the most are women between ages 30 and 60. And in many cases, there's not a clear cause. It can just show up for no obvious reason. And what this is doing is it's not harming follicles, it's not changing hair growth, but it's an escalation of hair loss. And if you think about that, there's a cycle of follicles becoming dormant and active, the anagen and the telogen phases. If a lot more go into telogen than would otherwise, your hair will thin. There will be hair loss. So there's less hair visible just because too many are going dormant at a given point in time. And in these cases, that daily rate of hair loss might be 400 hairs. It might be a lot more than it would otherwise. Now, you can have chronic telogen effluvium, but not have hair thinning, not have your hair visibly get thinner. So what I mean by that is you could be losing a lot of hair, but the growth is keeping up with that. But in most cases, that's not as noticeable. It's really noticeable when the hair is also visibly thinning. But there are times where women can see a fast rate of loss and have it be alarming, but really never have it progress to actual hair thinning. So there's a distinction. So thyroid disease and how thyroid disease relates to that. I want to talk about really thyroid levels, the thyroid hormone levels. Now, this is something that's counterintuitive. It's not just a matter of too little. It can be, but it can also be a matter of too much. And it can also be a matter of big fluctuations. So whether your thyroid hormones are, here, or there, any of those can do this. Often I'll see doctors assume that if someone has hair loss, they need more thyroid. And if their blood levels suggest otherwise, they still think they need more thyroid. Well, too much can do it too. So that's not the answer. The answer is always getting it right, getting it safe. And then the question is, how about the autoimmune side? What about the high thyroid antibodies? Do thyroid antibodies affect hair loss? I dug really deep on this and really not much data suggesting that it does. Not that it hasn't been examined, it has been studied, but There's one little piece of evidence suggesting that with extremely high antithyroid globulin, hair might be more fragile. So not so much more loss or slower repair, but possibly more breakage. And that's even equivocal. That's not even clear. But the difficulty was that these were very small differences, and this was a population that didn't have good thyroid function. So that's a big pitfall, is that whenever we think about thyroid antibodies, well, they're usually high in people that have abnormal thyroid levels, but they are different things. So there's a lot of people out there who are on thyroid treatment, and their thyroid levels might be well controlled, yet they still have high antibodies. And the question is that important? The best data we have is that shouldn't be a culprit for hair loss. Now, that's not to say that you couldn't be a woman on thyroid treatment with high antibodies and have hair loss. That can still happen. But in that case, we wouldn't think so much about the thyroid antibodies as being the key to stopping your hair loss. We'd think about, okay, what else could be relevant? How is your cortisol? Are your thyroid levels good? Are you nutritionally replete? Are you anemic? We just wouldn't think about that as being the main culprit. So yeah, the only real studies that have suggested that your thyroid antibodies have a big effect upon your hair health are the studies looking at people that have abnormal thyroid levels. But the few that look at those with normal good thyroid levels suggest that the antibodies are not important. So if your hair is thinning, your thyroid's dialed in, but your antibodies are high, that's probably not the most powerful lever to pull. That's probably not the biggest thing to focus on. So what can be relevant? Well, high cortisol, again, can be a big one, as we mentioned with the androgenetic alopecia. And we don't know I've not found data suggesting that chronically low cortisol or a bad cortisol curve, low morning, high night, rather than vice versa. I can't find data that can be a clear trigger, but high cortisol definitely can. So a good thing to sort out and treat. And by and large, most high cortisol is adrenal dysfunction. And it's really treatable. In the course of a few weeks, a few months, just by simple steps like I've put in the adrenal reset diet, you can get that back in line again. There can be high cortisol from adrenal disease, but that's more so like Cushing's syndrome or pheochromocytoma. These things are more rare. They do happen. They're more commonly diagnosed because they are more severe. So if you're wondering about having this thing off, definitely screen it, but just know that those are not as common to show up. So we also think about then high levels of androgens. Now, I did say they're most commonly implicated with androgenetic alopecia, but they can, in rare cases, be a factor with chronic telogen effluvium as well. So back to thinking about HRT, if you're on too much of a dose of DHT or testosterone. One quick aside with testosterone. How it comes in the body may be amongst the biggest predictors as to whether or not it causes hair loss with women. So in a woman's body, the main culprit is how much DHT forms. And DHT forms just from having testosterone there, but it's especially formed by a couple of enzymes. And those enzymes are in the liver and in the skin. So if you take a testosterone pill, your liver gets it first, and a lot of DHT can be made, which circulates. If you apply a testosterone cream, well, your skin gets it first, and you've got those same enzymes that can convert it there in the skin. So at Integrative Health, when a woman feels that she's a good candidate for testosterone and her levels warrant it, we recommend non-oral and non-topical. We do shots, shots or subdermal pellets. Those are versions that go into your bloodstream but don't have to cross your skin and don't have to go through your liver first to get to your blood. So we see a lot less DHT formation. And even at the same blood levels and the same level of symptom control, women are much less apt to have issues with hair loss when it's not going through the skin or the intestines. So yeah, quick little distinction with that. Now, a really big thing for hair loss and women is iron deficiency. And to be really precise, it's not just anemic, it's not just are you low hemoglobin or low in your blood cells, but latent iron depletion. So the first stages where ferritin gets low, that's where hair loss can be a factor. And counterintuitive, but it takes more of a deficiency to cause hair loss than it takes to reverse hair loss. I'm still not saying that well. I'm still not happy with how I'm explaining that. Let me put the numbers out there. So If you dip below 100, 90, 80, 70, 60, you might be totally fine. Once you dip below 50, really have to see hair loss. But once you get up to 60, the hair loss might not improve. 70, 80, 90, no improvement. You might have to get all the way up to 100 or above to see it finally improve. So yeah, there's an asymmetry between how much of a deficit it takes to start losing hair and how much it takes to fix that, how high up you get to fix that. So they're not the same numbers, which doesn't really make sense, but that's just how it plays out. Something else, things to screen for besides thyroid function, cortisol, anemias, this is actually worth screening for, is syphilis. So I was a bit surprised seeing the data on this, but it's really on the rise. So those who are just not in long-term relationships, those who are seeing, not even like, I don't know, not a lot of relationships, but just those who are still dating and not completely monogamous, it's not that rare. There was about 115,000 cases in 2019. And someone may have no real symptoms apart from hair thinning or hair loss. And it's quite easy to screen for. There's simple blood markers. So yeah, good thing to look at. So apart from obvious causes, what are other contributors? Well, one that's really well documented can be low protein diets. And that's somewhere below 15, 20% of protein by calorie. And not everyone has this happen, but many can. And the idea is that proteins are essential, but your body uses them in some ways that are more important than others. And when it comes to picking and choosing between maintaining cardiac function or immune response or keeping your hair going, your body lets the hair go by the wayside when it has to make that choice. So yeah, so critical, essential, complete amino acids can be important. And this is not hard to make up for just with your diet, but that can be an important consideration for those who are restricting some food categories. And hair fibers themselves are like 98% keratin protein, so it's critical to get adequate essential amino acids to form that. Other contributors, stress, anxiety, depression. Now, there's controversy about this. We do know that if they accompany chronic cortisol elevation, they can be culprits for hair loss. But we're not sure if they do it by themselves or only through mediating cortisol. There are times too to where stress and anxiety can cause higher rates of hair pulling, which of course eventually can damage and just cause loss when hair is pulled out. Other micronutrients can be factors as well. And besides iron, the best studied ones are probably going to be zinc and biotin. Now, zinc seems most relevant for really all types. So one big group of those that had androgenetic alopecia, telogen effluvium, were shown to be highly correlated with that. And also they showed that not only were they lower in serum zinc, but that zinc supplementation did improve symptoms. And that's an important thing. We want to make sure that it actually is useful. Zinc can be low on those who are on diets that cut out a lot of food categories, but it's something that we don't really know why it's relevant. We don't know a clear mechanism of action behind that. But it's common that those who are low in zinc might also notice their nails are brittle, they might have a poor sense of smell, and difficulties with wound healing. We also know that alcohol intake can cause faster depletion of zinc. So if you like your wine, you might want to stay on top of your zinc. That can be a factor for it. Biotin, this is talked about a lot, and it's gotten to take on, it's kind of a funny thing because in one sense, it's gotten to be a bit of an urban legend. Like if you megadose on biotin, you'll become a chia pet and you'll have hair sprouting everywhere, and that's not true. But I've been surprised to see that there actually are some good studies showing that many can be low in biotin, and that may be a contributor to hair loss even now. Much of what you'll read will argue against that, but one paper showed that women with no other clear explanation, 38% that were having hair loss, were measurably low in biotin. Now, by and large, it's pretty easy to absorb orally. We do see fewer vegan food sources that are very dense in biotin. A couple of examples of ones that are would be yeast and mushrooms are not too bad. But if you are vegan, you'd want those in your diet. Otherwise, you could easily get low. It doesn't take a ton of biotin. Really, if you're getting even over 100 micrograms per day in supplementation, you're probably in good shape. We use that in our daily reset pack, for example. It's well absorbed orally. People don't have big differences in how they absorb it. There's not big differences in how much we need. So it's a very easy thing to stay on top of it, but no need for massive amounts. There's data arguing that amounts in excess of 5,000 micrograms per day can be counterproductive for thyroid function. And any amount of biotin and supplementation can skew a lot of your blood levels. So we know that for TSH, for T4, for ferritin, for vitamin D, and now for coronavirus antibodies. Those are all things that you can get false readings on if you've taken biotin within the last 73 hours of getting a blood test. So it doesn't change your body in those ways, but it goofs up the results. So yeah, it can change your blood levels, so be cautious about that in timing it with your testing. You can measure biotin pretty readily in the blood. Serum levels below 200 nanograms per liter are considered deficient, and that can show up. Some can be lower than that. But yeah, by and large, if you are consuming a good variety of protein sources and getting some of the supplementation, it shouldn't be a big factor for you. So the thought too is, besides these things that can contribute to hair loss and these things that can actually cause it, is there anything else you can do? What do we know about nutraceuticals for being non-specific benefits? Well, most of our data here is going to be on chronic telogen effluvium, not as much on the androgenic alopecia, and really not on alopecia areata. So some things that have been decently studied, green tea is one. There was actually a good meta-analysis that pulled together 20 different studies, and they showed that green tea in supplementation can be an effective thing with chronic telogen effluvium. Another nutraceutical with some relevant data as well is N-acetylcysteine. So the thought there is that cysteine is one of the main rate-limiting building blocks for keratin. And oral N-acetylcysteine has some good effects on its antioxidant actions, but also upon creating the disulfide bonds that are needed for keratin production. And right now there's actually a phase 4 human trial looking at the effects of NAC in androgenetic alopecia in men. So we'll see what comes from that one. And then two more things. So silicates, compounds that are dense in silicates, such as bamboo extract. So there was one randomized placebo study on 48 people that looked at the effects of a silicate compound on hair. And the upshot of it was that within 9 months of supplementation, there were some pretty clear differences in hair thickness and hair density that didn't show up in the placebo group. So that could be a useful thing. And last up, there's some data about grapeseed extract, and probably more so topical, but can also be relevant orally, and it may work in ways like minoxidil or finasteride. So those who do want to do other treatments for it aggressively as they're finding the cause, we did put together a nutraceutical blend that contains those active ingredients. I used green tea, N-acetylcysteine, a bamboo extract for silicates, and a grapeseed extract. And it also has a few extra micronutrients that are relevant for hair health. That's our hair, skin, and nails blend. And yeah, we chose those evidence-based ingredients. So summary, action steps. First thing is know that this is a symptom, it's not a diagnosis. You want to get a proper diagnosis. You want to make sense if this is really more so a matter of androgenetic alopecia, chronic telogen effluvium, alopecia areata, or one of the other more rarer but inflammatory types of alopecia. You want to get a clear diagnosis. Dr. Kashaba can help those that are working with her. Also, you can look with your dermatologist, with a general practitioner, but yeah, get a clear diagnosis and know exactly what it is that you're dealing with. If you're seeing a lot of scarring, redness, or skin buildup, or flakiness, or scaliness, that may be one of the rarer types, and that can be good for a dermatologic evaluation. And then once you're aware of your type, you want to think about any obvious causative factors, any things that are really triggering this. The big ones there are thyroid disease, your iron levels, and your cortisol. Those are main things that can cause that. I would throw syphilis on that list too. It's rare, but it's not unheard of, and it's worth screening for, easy to screen for. Then we think about other contributors. So if you're low on biotin, if you're low in zinc, if you're low in protein, those things can contribute. They can make it worse. And a really cool point too is hair washing. I failed to mention this earlier, but so how often do you wash your hair for best hair health? This is pretty interesting. Some think that frequent washing damages your hair, it's hard on it. Well, I guess in theory you could be too aggressive, right? But normal washing is not harmful by any means. You can wash your hair and see some hairs come off in the lather. Those are ones that were going to come off anyway. They were about to fall out anyway. They just loosened up from the mechanics of shampooing and moving it. There's a little data arguing that more frequent washing is actually better, especially in cases of androgenetic alopecia. And the reasoning behind that is kind of like the reasoning of using minoxidil or finasteride, that basically the buildup of compounds in the scalp that has DHT, that's what irritates the follicles. So the more your scalp is cleaned regularly, the less buildup there tends to be. So daily hair washing can be a good thing that way. And I know how girls work with their stuff and their timing of hair washing. I know that's not always best for styling. I know they like to have a certain number of days between washing and whatnot. But just for overall hair health, and especially if you've got the androgenetic alopecia, more frequent washing might be better, and many dermatologists recommend daily washing. So that's it. If you've noticed this, get a diagnosis, know your type, know any causes, know the contributors, consider early treatments, consider some nutraceuticals, but it can get better and it can take some time. Just know that too. But also know that you can have thyroid disease and anemia and hair loss and have them be all unrelated to one another. It's totally possible. That's why it's always critical to diagnose these things. And even if you got something wrong that wasn't contributing to the hair loss, you'd want to know it anyway because that's important. And that's the thing, the more you can learn, the more you can correct, the better your body will do and the better all things will be. All right, take great care. I'll see you again real soon.